Hey guys, Justin Brock here. Today I have Bill Hepscher in the office. We're about to do a Behind the Agency, and Bill has sponsored the Behind the Agency. You know, when we go out and look for sponsors for the events that we do, one thing that we always try to find are people that we use, people that we would work with, and services that we know that are good for our attendees and our participants. And probably the one that, without a doubt, consistently comes to mind is Canadian Med Store. So, Bill, thank you for being here, brother.
Thanks, man. I appreciate it. It's always great to come to Tupelo. Let me say something real quick. I think, actors strive to go to Hollywood and musicians strive to go to Nashville, Tennessee. And when you're a Medicare vendor, Tupelo, Mississippi is where we strive to be. So being here in the studio at Bobby Brock Insurance, pretty cool, man. I appreciate it. I feel like I made the big time.
It's the Medicare motherland.
It's true. It's true. It's the Mecca.
The Mecca of Medicare. Yeah. Well, Bill's here. So we're going to talk a little bit about, what is Canadian Med Store for those of you that don't know. And then for those of you that do know, we're just going to kind of bring you up to date as there's clearly been a tremendous amount of changes with Medicare and the Part D program. And we're finding a ton of people, because of those changes, are falling off of plans, or they're not realizing they just rolled over into plans that have drugs that are no longer in the formulary, or they're hitting deductibles. The deductibles are much higher than they used to be. Occasionally, it is not advantageous for them to utilize their plan for some of these drugs when maybe they only have one expensive drug like Eliquis or something. So I want to talk to Bill about what Canadian Med Store is seeing in the marketplace, where they're really helping, and then how can you leverage them, and why should you leverage them to help your customers and help get you out of pickles and keep your customers happy.
So let me just give you a quick, I was coming up here today talking to some of your staff, and we were just talking about the evolution of the industry, I guess, and the major changes this year. So to tell that story, I think let me go back, 21 years ago when I first started my company. And I think you know this story, but some people don't. I didn't come from the insurance world, didn't come from the pharmacy world. I actually started my company, which has now become my life passion, to help people access affordable prescription medications. When my brother was diagnosed with non-Hodgkin's lymphoma at 27 years old, went through a bone marrow transplant, and even 20-something years ago, that medication was costing him tens of thousands of dollars. And what we found is that the exact same medication manufactured by the exact same manufacturer, probably in the same exact facility, one label for sale in Canada, one label for sale in the US, the medications that were costing us $10,000 here in the US were just a few $100s in Canada. So we accessed my brother's medications, and I came back and spoke to a physician friend of mine in Tampa, and he said to me, Bill, we write prescriptions every single day, and people just don't take their medications because they can't afford them. Now remember, I'm an old guy. This was 20-something years ago, 21 years ago. There was no such thing as Medicare Part D back then. So we started our company. We started helping people order their medications from Canada, and almost immediately we saw, like we're seeing now, the change in the industry. People who were going to Canada for their prescription medications didn't have any prescription coverage because there was no such thing as Medicare Part D. We're ordering from Canada. Medicare Part D came in, and kind of like we were hearing this year, there's this great thing. It's a $2,000 maximum out of pocket. Back then we were hearing, we're not going to pay more than $25 for our drugs. And any of us that have been in the business for a while remember that they went to fill those medications for the first couple months. People were calling us saying, hey, Bill, thanks so much for your help, but we don't need you anymore because now this new Medicare Part D thing is going to give us our medications for $25. About 4 and 5 months into it, the phone started ringing off the hook more than it ever did before, because they said, I just went to my pharmacy and my drug that used to cost me $100 is now costing me $300 because I'm in this thing called the donut hole. So that was the first big evolution, I think, in the world of Medicare. And that's when we started working closely with agents, because we knew we didn't know anything about prescription drug insurance. We certainly didn't know anything about health insurance. So we started working within that health insurance community. Fast forward for several years, and we're obviously in the world of Medicare. And the donut hole became the big boogeyman, I think. What people forget was that prior to Medicare Part D, there was no prescription drug coverage. So I always say the donut hole and the way it was planned was better than nothing, but now that became the big boogeyman. And anybody that knows about the design of Medicare Part D knows that it was set up that way because the administration and Medicare in general wanted folks to have some skin in the game, but they didn't want folks to go bankrupt over their prescription drug coverage. And that's why when they figured out that $5,000 number, started out around $3,800, was the spot that was going to be the big turning point for people. That was the real sticking point, and that's when catastrophic coverage would kick in.
It's so wild because if they actually met with these people individually, the way that some of the politicians claim to, they'll tell some story about somebody that they never even talked to use it to sell some idea. But as someone who talked to a lot of them and who runs, organizations that talk to a lot of them, the donut hole amount in and of itself, yes, it is better than nothing. And now, yes, the MOOP is better than nothing. But so many of these people, they see 2,000, they see 5,000, they see 7,000, 8,000 in the troop amounts. Those are catastrophic amounts to them. These are people that are living off $1,200 or $1,300 a month.
Big numbers, and so you're right. And I'm certainly not trying to speak down. I'm talking about in the design of the whole thing. But you're completely right.
They had that was their intention. It's just the budget of the average retiree is so low,
And you have to remember that the argument of saying, well, we just need to keep it like where the drugs are just covered through. There's not enough dollars there. We're already in such debt from a national perspective that they said this is the way we'll be able to.
They can't even afford what they are doing.
They can't afford what they're doing. So as you fast forward, as I babble on, but we fast forward into where we are currently right now, finally, and it was the political optics that looked really good. Let's make the number 2,000. The average person can afford 2,000. Let's just make that number.
Yeah.
But as you know, right before they were going to kick out the plans and introduce them to everybody, they said, oh, shoot, we're going to see an increase of $176 average premium. That won't look really good when people get those renewal notes, especially right before a presidential election. So let's change this and let's offset it. So the costs that were supposed to be shifted from the government, from the taxpayers onto the insurers, onto the plans, although that happened, it's also being largely subsidized through tax dollars.
Absolutely.
But where people are coming in, at the end of the day, we can talk politics, Justin, we can sit here all day and do it. At the end of the day, we all have clients who are saying, I can't afford my prescription medication. And even though there's that $2,000 maximum now, unfortunately, because of that, the plans have now had to limit the drugs that they're covering. So we're seeing less and less drugs being covered. We're seeing more and more drug costs go up. We're seeing deductibles in there. So folks are still stuck paying that bill. And that's basically where the Canadian Med Store has stepped in. For years, we've been helping people avoid the donut hole by buying a drug from Canada. It wouldn't apply towards your maximum out of pocket, which means you can get all your other drugs before you hit your donut hole. Now what we're finding is that folks that can get to 2,000, if it's going to be beneficial to them, we don't want them to order a drug from Canada. We want them to go through their health plan. But where we're able to step in is often when folks see those medications that are no longer covered because their plan has changed or now their deductible is so high. Well, heck, if you can get your Eliquis from Canada for $50 a month, that's less than what your deductible and your co-payments are going to be. So there's still a reason.
If that's the only brand name you're taking, you're not going to hit the $2,000 maximum out of pocket typically. So.
That's right. So yeah, you're right. So if you're only taking that one brand name drug and you're taking a bunch of other generics, then you can fill your Eliquis through Canada. The other thing that we just talked about, though, is what's happening to those folks who ignored your calls about, hey, it's time for us to review your plan. They didn't. They looked. They said, oh, my drugs are still here. I'm on the same plan. Nothing's changing. They didn't make a change. Well, now in the first week in January, they went to fill their prescriptions, and they found that there were some changes. That now their drug is no longer covered, or their drug is covered at a much higher copayment, or now they have a deductible, and they're calling you, say, what can I do? Well, we're outside of the enrollment period right now, right? Especially if they're on a standalone Part D plan, they can't make a change. Well, everything isn't lost now. They might be able to go to Canada to buy that one really expensive drug. Or what about even if you can make a change from an Advantage plan to another Advantage plan? Well, maybe now they're going to have to find new doctors, and they're going to have to find new clinics that they're going to have to visit because they need to get that drug covered. Well, maybe not. Maybe if their physicians are still covered under the plan they're on, but the Eliquis is what's causing the problem, well, heck, we'll buy it from Canada, and you can still stay on the plan that you're on. So I guess the thing that you and I have talked talked about for years is that Canadian MedStore is not replacing Medicare Part D. What we're here to do is be another tool in the agent's chest when they run into that problem, when they get that call from somebody who says, when we picked this plan, I wasn't taking this drug, but my doctor just prescribed it to me and now it's not covered under the plan that we're on and I can't change for another year. What do I do? Well, Canadian MedStore is going to be an option for that.
Yeah. And so when we're looking at solutions, why wouldn't, and we've talked about this, but I'm just kind of just get your take on it. Why wouldn't someone just go online and look up, get my drugs from Canada? I know the answer, but I want you to tell us.
I think there's a few reasons. Number one, there was just recently a report that said that 90% of the medications that are filled through online pharmacies are either counterfeit or misbranded, especially when you're dealing with a pharmacy or a supposed pharmacy overseas. There's no regulation over that. So I'm not saying some people might have a good relationship with an online pharmacy, but there's a concern there. If you're sending a client somewhere, if you're just saying, hey, go Google Canada drugs and you'll find something, you're going to have a bunch of websites that pop up, and about 90% of them are probably going to not be legitimate groups. That's one reason. I think that when you're dealing with the Canadian MedStore, we're based out of Tampa, Florida. We're a U.S. company. We do just like your agent community does. We work as the agent for that client. We're going to make sure they're getting medications from a legitimate pharmacy in Canada, legitimate pharmacy in England, Australia, New Zealand, wherever we're sourcing it from. We're going to help them through the process of ordering it. We're going to help them in the process of shipping the medications. The one thing I'll tell you, though, that most agents tell us is that they prefer working with the Canadian MedStore because they've worked really, really hard to build their book of business. And what separates them from the other agents in their community is that their clients know that they're there if they want to call them and ask them a question about their plans. They want to secure that relationship. Last thing they want to do is just send them to a website somewhere. They want to send them to somebody that they know that they met. So every single agent we work with and every single client we work with will be assigned a concierge. So when Justin refers somebody to our company, they're not just going to be referring them to a website or a call center. They're actually going to be referring them to Amber or Pam or Corey, somebody on our team that's going to handhold that client through the whole process. So it's really the customer service, I would say, that helps the most. The other thing is, by the way, we do pay a $10 referral fee for any referrals for the life of the customer. So typically our clients order medications every 3 months, so 4 times a year. So typically a client referral is worth $40 a year to any agent that sends that referral. I have to be honest with you, no agent has ever gotten rich off our $10 commission. But the feedback we hear is, listen, it's about what I'm getting when I'm writing a Part D plan anyway, and it's helpful for me to do it. But the most of the feedback
sounds like free lead money to me.
let me tell you, this is where a lot of agents have come back to us and said, you know what, I use those dollars to then buy leads. I use those dollars to reach out to, other, doing maybe an event for my clients or something like that. What I think the really, really smart agents are starting to do is they're recognizing that they're trying to build relationships within the community with physicians. And one of the ways that they can help with the physicians is not just to walk in and say, by the way, I can help you with your, with people that you want me to write Medicare Advantage for, but to go in and say, hey, doc, I've got a relationship with a reputable pharmacy or reputable company in Canada and in Florida. Do you have a lot of people taking Eliquis? And almost every single doctor will tell you yes, and it's my number one concern because people come into my office, my patients, and say, I can't afford this, doc. I just don't take my medication. So they would love to have a way to help refer that. Well, if you're the agent who helped that doctor find 100 of their patients a place to find their Eliquis that's affordable, don't you think you're going to be able the one that's going to be referred when they need somebody to write a Part D plan or a Medicare Advantage plan or a supplemental plan? So it's a way, again, to utilize our service that 9 out of 10 agents in your area aren't utilizing.
No, we absolutely do utilize it and need to utilize it more because we're coming up now at the beginning of this year with a lot of people hitting those drug deductibles. Actually, John Patterson, one of our top agents, just asked me, he said, do you think these Medicare Advantage drug deductibles are going to come back down, right now? And immediately my thoughts are actually on the drug side, it may get a little worse next year. I think there are going to be some other improvements in the Medicare Advantage plans as they start to get, maybe properly increased funding, over the next year going to the new plan designs. But And then there was also the V-bid ended recently, which is going to take some money away from some of the additional benefits that might have been used to supplement some of that, like the flex card and OTC benefits. So I think that it's probably only going to get worse on that front, because when a company is forced to pay more of the catastrophic amount of something, they tend to say, what can we control? We can increase deductibles, we can lower the formulary, we can increase co-pays, but we can't, at a certain point, we're going to have to pay after $2,000 in expenses on drugs, right? Mm-hmm. So let's pass on. So really the consumer that is only taking Eliquis or generics, they're the ones that are going to get kind of hammered on that forefront. It's not the people that we're taking $10,000 worth of meds a year. This is a winner for them.
Huge.
But from what we could see, that might be 20% of our customers, versus most of our customers were falling under that $2,000 in out of pocket, but they could still be close to that $2,000 and really be paying more than they want to pay or can afford.
Yeah, I would tell you that I compare a lot of what the changes that happened with Medicare this year, Medicare Part D, largely with something like the ACA. And the reason I say that is with the ACA, remember we said, everyone's going to have to pay X amount of money, and you're all going to have insurance, and it's going to work for everyone. Well, the guy who couldn't get insurance because he had pre-existing conditions, or the guy that was uninsurable because he had too much stuff going on, he benefited from that because his cost was the same as everybody else in his area, was nothing more. But the guy who was healthy, didn't have anything going on, was already thought he was paying too much in his premium, is now paying more to offset the cost of that sick person. Same thing with Medicare Part D. I've read estimates that only about 10%, to 1 out of 10 are really going to benefit from that massive thing. If you have someone who's spending, $16,000 or $20,000 a year in their medications, and now their maximum is $2,000, huge win for them. But the typical client that you guys see, 9 out of 10 of them are the ones going, wait a minute, I never thought I used my Part D. I thought I was already paying too much for my Part D because I'm only taking a couple of generic drugs, or I'm taking one generic and I'm taking Eliquis. I always thought I was paying too much for my Part D because I have to pay a premium, I have to pay a deductible, then I have to pay my copayment. And at that point, I could just go buy it for less expensive. Why am I doing that? So 9 out of 10 people are going to be angry and actually are going to be paying more. But the only way that we can offset the cost for that one person that needs to be covered more, that's the way it's going to work. To tell you, I would bet you we can sit here again next year and I will tell you that it's only going to get worse when it comes to costs. And the reason for that is under the Inflation Reduction Act, when they created the changes, the budget was already kind of sketchy of where the money was going to come from. When they had to shift and make those last minute changes to actually keep the premiums down, no one really even knows where that funding's coming from. So that funding that money has to come from somewhere, which means we either have to get that from the federal government, which I'm assuming we will do, but how long can that continue to last? And the only other thing I'll say to you is I think we're going to see a compression of actual plans that are being offered. We already saw it this year, where a lot of times when they were offering 4 different plans, now you see somebody maybe only offering 2. I personally believe that a lot of these companies that came out with really, really expensive, really, really bad plans, it was because they were asking people not to buy their plan. We want to get the heck out of Medicare Part D. We don't want to do this anymore. Yeah. We saw that with some of the blue plans. Yeah. Hey, listen, this is like, we're going to increase the cost. We're going to lower the.
We saw this with Advantage plans, even on the commission front. Sometimes when they would say we're not paying commission on it anymore, it's not because they want the business but don't want to pay for it. It's because they don't want you to enroll people.
They don't want to. They were paying people not to buy their plan. Yeah. Or they weren't. That's what I mean when I'm saying they were saying we don't want you to buy our plan. That's why we're not going to pay a commission. That's why I say that to agents all the time. You have to remember that not paying a commission isn't because sometimes it may be, but sometimes it's not because they want to put it in their own pocket and keep it. It's because they don't want to sell the business. They recognize some groups. And we can talk about this off camera. Some carriers are pushing away from the agent community, saying, hey, we've done everything we can to capture market share. Now we don't want to work with agents ananymore. Yeah. That was a plan.
There was definitely one company on the Part D front that I think did that based on like kind of the way the numbers fell. There was definitely others that handled it more gracefully, that I think that they wanted to maintain the relationship with brokers. There were certain products they wanted brokers to push, but why, like if we're a distribution group, why pay people to distribute something that isn't a profitable product for you.
That's just it. Why would you want to pay? And the other thing is, it's also you have to look at it from the political part of it too, to come in and just say, we're only going to sell products that are really, profitable to us. We're not going to sell anything else. Politically, it's difficult to just say, we're not going to do that anymore. We see that in Florida with a lot of the insurers when it comes to homeowners insurance. They're getting a lot of political pressure because they're saying, hey, we just can't insure homes here anymore. Yeah. It's probably a good business decision, but it looks really bad PR-wise. Yeah. And that's why a lot of these companies said, we can't just pull out of the Part D world and say, well, there's no money in it for us anymore, so let's just make our plans really, really bad. Nobody will enroll, and eventually we can
some of these carriers that I've talked to, the designers of Part D plans for them, that they were upset that they didn't raise their premiums enough because they're getting more business than they thought they would. Right. As a matter of fact, even in the Advantage community, because you think about Medicare Advantage plans, they have drug elements to them. There is Part D plans in most of the Medicare Advantage plans. And there was a lot of plans after AEP kicked off that said they were going to end commissions for plans, certain plans submitted after November 1st. And it was because they were getting more business than they intended to. And when you think about their funding mechanism, they have star ratings. And if their star rating drops because their service can't be as good because they can't afford to service enough of those plans, it might be that, hey, we can deal with 2,000 people in this market on that plan, but if we had 5,000, the revenue cycle would really be disruptive to our profit margin. And then they see that they're going to hit 5,000 in that market, and they're like, they quit paying because they're like, let's see if we can get the agents to steer those away from us. Right. It's not because they don't want to pay the commission. Most of the time, I think it's more of we need you to please push this business elsewhere if you can. Right. And sometimes you can't, and sometimes that's a pickle for an agent, especially if you're in an area where you got two viable plans and everybody was on this when you're moving them to this one, and then that one quits paying commissions. So I dealt with agents that were in that situation, and I feel for you, but at the same time, we're partners of the insurance companies, and we try to keep people there's a world where we can all, win as much as possible, so let's aim for places we can win. And where I think we can win with Canadian MedStore is it's one more resource to take care of our customers. I think in a lot of ways, sometimes it actually benefits a lot of times it benefits the insurance company. If it benefits the client, the insurance company, and the agent looks like the hero, and that's the triple win, right?
Amen. So I'll say a couple of things about that. Number one, the triple win is real. I talked to you about a $10, finder's fee that we pay to agents. Agents tell me all the time, the successful agents tell me all the time, $10 is nice, but it's about the fact that when I saved this guy on his Eliquis, guess what? If they're playing golf with their buddies, they're all taking Eliquis. They're all kind of back in the old days with the ED medication, but they're taking Eliquis, they're taking Pradaxa, they're taking Januvia, they're taking an expensive drug. Well, once he tells the guy, hey, my agent, Justin, told me about this place, I get it for $50, all those other guys are calling you now to say, hey, I want to get my Eliquis for $50, or I want to get my Januvia, or my wife is taking XYZ drug. You better believe that guy is going to be, if he doesn't have a good relationship with his Medicare agent, and even if he does, now you're the guy who just helped him save $1,000, a quarter on his medication. You better believe he's calling you when it comes time to do that. You also have a compliant way to reach out to some of these people and let them know what's going on. Secondly, I'll say we talked about relationships with physicians, which is huge, because I can tell you right now, if people come to us from their physician or from their agent, they don't even question about the whole process. They're just saying, hey, my doctor told me to come here and get my prescription and ready to do it. The trusted relationship between a patient and a doctor is huge. And if that doctor is the one who says, go talk to Justin about your Medicare, that's big. The reason I'm saying this, though, is that doctors, just like the insurance companies, need their star rating because they're paid on a capitated plan. So if you guys aren't aware of this, they're going to get paid more or less on how well the outcomes are for them. Well, physicians get frustrated all the time because they say, I did the right thing. I prescribed the medication. What more can I do? I can't show up every morning and make sure somebody takes their Eliquis. Well, if they're not taking their Eliquis because they can't afford afford it, the doctor wants them to be compliant on their prescription medications, not only because they want their patients to be healthy, but because their compensation is based on how well their patients are doing. Less hospitalizations mean they get more money. Less having to refer them to a specialist means they get paid more. So if you can be the one that helps that doctor do the right thing and keep their patients healthier, that doctor is going to get paid more. You better believe your relationship with that doctor is going to be better than some other guy who comes in and says, can I sit in your lobby and
sell insurance?
Sell insurance.
Yeah.
It's about building relationships, I think. And that's why you and I have been working, because it's about relationships, about people you want to work with, the people you trust, and people you like, right? But if you can help somebody make money, they're going to like you. You know what I mean? So
Absolutely.
I guess I'm just saying that. And ultimately, if we really want to, feel altruistic about this, somebody who wasn't taking their medications because they couldn't afford it is now affording their medications, and they're healthier because of that. They're going to refer you more clients, and at the end of the day, as a society, we're actually going to spend less money on healthcare, because I say all the time that prescription that a doctor writes is not what keeps somebody healthy. They actually have to go to the pharmacy, fill the medication, and take that medication compliantly. So ultimately, if we can keep people healthy and not just have to pay when there's that hospitalization because they didn't use their inhaler like they were supposed to, now we've kept the costs down.
Yeah.
So.
Yeah, and that's how we'll actually help the budget more than Congress will.
Imagine that. That.
Well, we really appreciate Bill being in. Obviously, Canadian Med Store is going to be a great solution for many of you. How can people find you, Bill?
Yeah, we're going to share a link with you. If you can share it on the at the bottom of the page or whatever it would be. Our website is CanadianMedStore.com, but we do have a very specific link that we'll share that you can go on to, click, and then you'll be put in contact with one of our concierges. Our concierge will reach out to you, walk you through the whole process, share any marketing materials with you, and then that will be the person that when you refer a client, you're not going to simply send them to a website somewhere. You're going to be able to say, hey, I'm introducing to Pam or Corey or Amber over at the Canadian Med Store, and this is the person that's going to be able to help you out. And if you're sitting there with a client and you have a question, you can pick up the phone and talk to one of our people. We're there for you. So we'll share all that information, CanadianMedStore.com. One last thing I'll say, remember, it's not just Medicare. We see a lot of people, a lot of your agents work in the under 65 world, and we're seeing a lot of people on those high deductible health plans more and more under the ACA. So remember, even if somebody is not on Medicare yet, they can still utilize the service.
Perfect. Yeah, I was actually going to ask you that earlier, because we're writing a lot of ACA. A lot of our communities writing ACA. It's a tremendous play. If you're not writing ACA, it's a great side, at least to be able to help the spouses of your customers, and you're going to run into more of those. Probably even a higher percentage of those people if they're taking one of these medications.
Yeah, we're seeing a lot of that, by the way, Justin. People who are going to be your Medicare client in just a few years. The husband has turned 65, the wife is a few years younger. She's on some high deductible ACA plan, or she's just keeping her fingers crossed and hoping she just doesn't get sick until she turns 65. Mm-hmm. When they're asking you about that, this is an opportunity to help keep those costs down. Once again, if you can help them with that, you've cemented that relationship. You've got a pipeline now that you're going to be able to, if you're not selling them ACA, you're going to at least know that you're going to be able to help them with their Medicare in a year or 2 or 3 from now.
Perfect. Thank you guys so much. Check out CanadianMedStore.com. If you haven't got your ticket to Medicare Con, head over to MedicareCon.com. Bill's going to be there. So go shake his hand. Thank you.
Thank you.